change tack a little bit and invite a speaker who actually represents the private sector in Bangladesh. He actually runs one of the oldest diagnostic, or perhaps the oldest diagnostic center in Chittagong, which is the second city in Bangladesh. Shadab Mahmud. He began his career as a program manager of Grameen Healthcare in Boston, where he established an innovative social business partnership with Pfizer, with GE Healthcare, and the Mayo Clinic. He has since held various positions, both in the public and private sectors. And as I mentioned, he's currently running this very large diagnostic center in Chittagong. So Shadab will provide us the private sector view of the role of the private actors in the health sector in Bangladesh. So rather than just talking to ourselves, as most of us tend to do as public health professionals and practitioners, I think we're going to hear a view which I hope will be provocative and somewhat different from what we normally hear. Over to you, Shadab.
Okay. I've immediately faced some technical difficulties. My notes aren't coming up, so I'll refer to this. Okay. Thank you, Ramesh, for the introduction. Let me start by saying that as the proud owner of a private sector healthcare diagnostic center in Bangladesh, my objective here is to dispel myths and reinforce realities about this largely unknown and misunderstood private sector healthcare industry. Understand first that the private sector healthcare is highly lucrative because of the gaps in service provision left by the government. This is especially true in urban areas where the focus is on secondary and tertiary curative care. Moreover, an epidemiological shift of NCD towards NCDs and an aging population means there is an accelerated need for diagnostics with or without consultations. Indeed, the private sector silently sustains Bangladesh in its journey towards UHC, and diagnostic centers play a critical role in the value creation of healthcare in Bangladesh. So here's what we do well at a glance. We ensure access to quality healthcare services by providing high quality care to customers. We drive the urban healthcare system. We do this by investing in a qualified workforce. And finally, it might sound strange to you, we correct the inequities in healthcare system, and we do this by helping patients make better healthcare decisions to reduce their costs and improve their outcomes. Now, while there is great business opportunity in the diagnostic space for growth, there is also huge business risk. Reaching the blue oceans require a combination of provider relationships, customer analysis, timely technology investments, and heavy services marketing. Now, the business model has a relatively small organizational footprint and caters to a high volume of retail customers from all levels of society. This provides a high level of market sensitivity and tremendous agility in innovation relative to larger health providers like hospitals and clinics. Diagnostic centers also occupy a very small footprint, a neutral market space, with customers seeking service from different provider levels, both public and private. There is thus the real opportunity to influence both provider and customer behavior and affect industry standards and practices from this position of neutrality. And finally, contrary to popular myth, we do not turn the poor away. Actually, there is not a single poor person who does not get the discount they need to avail the basic pathological services, right? We even pay their transportation fare if necessary. Why do we do it? Yes, we can afford to, but it is always important that that's a choice we make each and every time. And what we get in return is social capital that enables us to better navigate an increasingly challenging business environment that is plagued by corruption and special interests that threaten to counter the vision of UHC in Bangladesh. What are these challenges? The biggest long-term challenge to the private sector is really the private sector itself, its quality, right? There's a mushrooming private sector skeleton diagnostic space with only the license and barely any technology investment or investment in qualified human resources. What they do is they send the collected samples to reputed diagnostic labs for a fee, if at all, and therein lies the problem. And the root cause of this is a lack of regulation and misenforcement. Large labs like ours get punished for the smallest of discrepancies, as we should be. But the skeleton labs get fined minimally. When you have nothing, there are even less things that can go wrong. So what this incentivizes is a market for very low quality skeleton diagnostic centers around the country. And this drives the overall quality of diagnostics and healthcare down. Just taking a glance at the care dynamics of Bangladesh, we see that 60% of the people seek care from the informal sector. And of the 40%, the large majority come to the private sector, where in spite of having to pay. In terms of where the money for the healthcare comes from, we see Bangladesh suffers from a huge burden, 67% out-of-pocket expenses. The government and the donors chip in the rest. And because the government and the NGO providers are basically free or low cost, the private sector plays a dominant role in this huge out-of-pocket expenditure. So out-of-pocket is a private sector problem. If we deep dive into that 67% out-of-pocket expenditure and break it down into components, we see that the large majority is spent behind medicines. Diagnostics account for 30%, another chunk. And we'll be only looking at the diagnostic space with regard to out-of-pocket. Now, what if I told you that the out-of-pocket of 67% could be slashed by 8% to 59%? That's the national out-of-pocket almost overnight without collapsing the system or investing in complex and costly health financing mechanisms. Theoretically, it can be possible by addressing the hidden problem of refer fees. Now, usually, what happens is physicians at hospital clinics refer patients to diagnostic centers for tests. Unfortunately, what refer fees are is the refer fees are the payments made to these physicians for referring patients to us. And the current average market rate for refer fees is 40%. And strictly speaking, it is a simple business arrangement, but with the amount dictated by the free market. But this has dire consequences for the patient. You see, refer fees is such a standard practice in Bangladesh that we have to account for it as an operational expense, which is ultimately loaded onto the service fees to the patients. So the patients end up paying 40% more for diagnostic services than they otherwise would have. And where does this all start? Believe it or not, it all starts with the intern doctors at the medical colleges. They start in this cycle of corruption pretty young nowadays. And we're in a catch-22 situation, right? If we stop giving the doctors the refer fees, they stop sending us patients, and our business that has run for so long just goes down the drain. So that is a problem. But the point I want to make is this is a real problem, and by just tackling it, this hidden issue, we immediately bring down the national OOP by 8% theoretically. So I want to make this apparent that we need to change the conversation about OOP. What we normally talk about is the gross OOP, which is full of these artificial costs. Let's start talking about the real, or in this case, the realer OOP. Well, the story does not stop there. See, it gets more interesting. Shareholding is another such problem driving out-of-pocket expenses in Bangladesh. Normally, the in-house doctors would be a salaried position with the responsibility to see patients and prescribe necessary tests. However, doctors practicing within the private sector providers have the unethical opportunity to invest in the organizations they're practicing in. So in such a financial arrangement, which is becoming increasingly common, providers are able to expand their business, and the now doctor shareholder enjoys dividends from the profits of the company. And large providers can have anywhere between 50 to 100 such shareholders, almost a pseudo-publicly traded company. And this is beyond any standard refer fees they might receive. So this essentially shifts the incentives of the doctors from neutral caregivers to branded retailers. The more tests a physician prescribes, the more the company profits, and the more dividends the physician enjoys. And we can certainly have a solution by regulation banning doctors from operating in institutions they own. So we can see further opportunities to reduce out-of-pocket and move closer to a real out-of-pocket. So the effects of these hidden cost intervention are it lowers out-of-pocket and ultimately leads to better health outcomes because these increase the formal sector care seeking and formal sector care completion. So in terms of a way forward, I have 3 points. First, we must leverage private sector data for public health goals. We are a hotbed of data about out-of-pocket expenses, burden of disease, levels of prescription of tests and drugs, provider behavior, and the real policies that are being implemented on the ground. We also need the public health agenda to account for these hidden systemic challenges that lie beyond the data by implementing quality regulations focused more on system efficiency and outcomes, not just infrastructures and services. And finally, the national health policy needs to espouse the private sector as an integral and all-important part towards the solution of out-of-pocket burden and a resilient urban health system in Bangladesh. Thank you.
Thank you very much, Shadab.
Sorry, over time.
No, you did perfectly. It isn't often in public health conversations that we hear words like returns on investment and sort of branded shareholders and things of that nature being talked about. So that was in itself a refreshing change. What was perhaps even more refreshing was to have some very practical, commonsensical solutions being offered from the private sector side on what needs to happen if you're actually going to engage the private sector in reaching out towards resilient health systems. So thank you very much for that. Okay, we're going to now pause. I promised you that we will make this interactive. So this is your opportunity to to ask questions of 3 panelists who just presented. So questions for Rubana, Elena, and Shadab. Okay, if you could just raise your hand so that I can see where, we'll just go in order. Did you have a question?
Oh, yeah.
Okay, so we'll just go around the tables this way, clockwise. If you could introduce yourself, please, and then ask the question.
Let me see, because it's for the first presenter, so I kind of forgot what I was going to ask, so I need to look at my note. Okay, so in your presentation, you showed the statistics about like road traffic accidents happening in probably urban areas. Is it global or? So, I mean, my comment was that, I mean, my understanding is that road traffic accidents actually is not a very good example in the context of like urban problems, because most of the deaths and injuries that occur in the highways, not in the urban centers. So the urban centers are kind of immune to this sort of thing. So as a background, when you present this data, it's kind of confusing. So anyway, just feedback.
Okay. Sorry, you had a question?
So that was actually for Rubana. And for third speaker, actually, I had another comment. I don't know, it's not a comment, it's just a clarification. You mentioned that the cycle of corruption starts with the intern doctors, right? But it's not very clear whether the doctors go to the private sector asking for this rent-seeking type of behavior, or is it the private sector, persons or the marketing representatives going to the doctors and making them corrupt? If you have any comment on this.
Very interesting questions.
Chicken and egg question, actually.
Let's hold off for just a little bit. Let's take 3 questions at a time, because I see a lot of hands up. So if we could move to the next table, and the gentleman and the lady there.
Hello, I'm Wim van Damme from the Institute of Tropical Medicine in Antwerp. So the second speaker, especially, you present a number of common practices and ways of functioning of the private sector. But to what extent are they specific to the private sector? Because many of these seem to me quite common in the public sector.
Okay. Ma'am? Yeah.
Just related to what Tawfiq said, that question to the Shadab, that actually I disagree with that kind of a justification for the private sector that if we stop giving the money, they not see us the patient, send us the patient. The number one example is ICDDRB lab. They don't give the money to the doctor. So if you provide quality service, actually the patients will go there. And the secondly is that another consequence that I think should be included is not only the cost of the patient, the doctors what they also include unnecessary tests, which also actually kind of expose the patients to go through different kind of radiology, that MRI, that blood test. So I think these are the 2 points I just want to mention.
Thank you. Okay, so let's pause and give an opportunity to the panel members to respond to that.
Just on the question of the public sector, utilizing some of the same strategies, quite possibly. I think that because of the practice of dualism, the public sector doctors are very much part of this. This wasn't a study about the public sector in particular, but I think there is some of that behavior, obviously.
To the point of how does the corruption start with the intern doctors, it's not clear. I'm not a researcher, but it's there. It's apparent. It happens ward to ward. We go and it does take some guts to be a private player and come out and say this, but we have the money going there to prove it. So regardless of what you might think, we are sending money to these wards of these public medical schools and paying these intern doctors. And others are, by the way, it's such a competitive environment, right? So, and to the point that the quality of the lab is good, patients will go anyway, that's highly theoretical, because being 20 years in business, it is. It just doesn't happen, so you can, disagree.
ICDRB is the example.
Well, ICDRB is different. I think it's pretty specialized. We're a diagnostic center. Diagnostic centers are opening up right in front of the medical colleges, and we haven't moved. We're somewhere else. There are dalals from or middlemen from the other diagnostic centers waiting in front of us. It's a pretty nasty environment. And in Bangladesh, the patients will go wherever the doctors tell them to. I mean, believe me, you might have your own opinions, but I'm running a business with my own money, putting things in behind marketing. I know how things go. If I don't pay off the doctors, yes, of course, 15% of our patients come on their own, certainly. But the other 70% are sent by doctors. And there are huge falls in the next month of sales if we don't send the doctor a refer fee. So these are realities. I mean, I don't think there's anything wrong in translation, maybe perception is, but that's us. And yeah, I think I'll stop there.
Thank you. And to the extent that the people asking questions are not entirely satisfied with the answers, I think it opens up the possibility of, while you're enjoying your coffee, to continue this discussion. So let's move to the next table. So.
Sure. So I'd actually like to hear a little bit more about the issue of discounts, because I seem to recall ICRB did a study not so long ago looking at the tremendous debt the poor took on when they went to private facilities. And it'd be helpful to hear a bit more.
Absolutely, great question. First, so I was actually telling my colleagues yesterday that the private sector is not one blob, right? It's a lot of different players. The private sector is very pluralistic. So I'm a diagnostic center. I'm not a physician. A pharmacist is not me, and I'm not a pharmacist. And so we all have these different dynamics that we play off each other, right? So yes, the point that Malavika made about overprescription of tests, certainly we don't have the authority. We know. After you've gone through 10,000, 20,000 prescriptions entering into a diagnostic database, you know which tests are unnecessary. But we do not have the authority to tell the patients that this is unnecessary. Because again, we don't want to antagonize the doctors. So it's a pretty fine line, and we know where the lines are. It's not like it's unclear. In the private sector, we know where the lines are. We don't cross it. We can talk about it and discuss with each other. We can negotiate the RFs, but that usually doesn't work. So to keep in mind that it's a very uneven playing field with a lot of players, and we're doing our best, and I'm sure each of the other players have their own stories.
Thank you, Shadab. I realize that some of the questions that are being asked are provocative, and
Oh, it's fine.
Perhaps you feel that an immediate response is called for. But let's be patient. Let's take 3 questions at a time, and then we'll come back with answers from the panel. And in addition to introducing yourself, if you could kindly address the question to a specific panel member so that they know whom they're responding to. So, the gentleman there, and we'll come all the way around.
Michael Titus, Scenarium Berlin. I would be interested in hearing a bit more about the demand side. Rubana, who I'm addressing the question to, had a slide that said private providers are favored over public. So apart from the fact that there is an abundance of private facilities, and we've had heard a few more facts, and that the service hours are attractive, etc. What drives the demand side? What are barriers to accessing public services?
Excellent question. Okay, please.
My name is Mara. My question is for Elena and Rubana. I was thrilled to see your mapping data. I was part of a study that did a very similar set of exercises in Nigeria recently, looking at a very similar set of questions. It's fun to see the similarities. My question for you is, did you study the provider characteristics of the drug sellers? I asked that because in Nigeria we found a diverse set of people operating as, quote, drug sellers. Once we were able to break that down, we could think about ways to engage what is an overwhelming number. And I'm wondering, if you didn't study those provider characteristics, how are you thinking about segmenting that sector of providers to engage them, given that it's so large?
Great. Okay, I think that's the final hand there. Please, you've been very patient. Thank you.
My name is Paul Webster. I'm a medical journalist for the Canadian Medical Association Journal. And I just right off the bat want to say, fantastic panel, really interesting. Shadab, I think, should be the keynote speaker at the next.
I take it that's a vote of confidence, not just for Shadab, but for the private sector in general.
I'm a journalist, and it's interesting to hear the truth spoken. But my question is actually to Alain. You mentioned that the critically ill patients tend to be referred to the public. And perhaps I have a suspicious mind, but I have to ask, does that mean that the public sector facilities are dumping grounds for defraying the risks of the private sector? And if that is the case, does that mean that the public sector is in fact serving the private sector as a kind of dumping ground? I know that sounds terribly morbid and almost cynical, but I have to ask that question.
Excellent. So fascinating range of questions. Who wants to go first?
So I'll just address the question about what drives the public to private sector. I think we'll hear more about that in details from our next 2 presenters. So hopefully you can be patient until then. And regarding the other one about segmenting the whole private sector and looking at them, part by part, I think we haven't done this as yet, not in this study that we have done, but that's something definitely we have thought about, because we know, as he kept mentioning, it's not very homogeneous. It's so many different players, and we have to deal with them differently and look at them differently. But that's in the plan. Yeah.
Just to continue on that front, in terms of segmenting, you're talking about drug sellers in particular. What was really interesting is one way of segmenting them, obviously, is segmenting according to qualification. There are some who are qualified, pharmacists, and others that the large majority aren't. So that would be a clear cut sort of differentiation one could make. But I think it is important to dig deeper in terms of the drug seller kind of motivations and strategies, because I don't think we know enough about them to know how to gauge. I mean, there have been various efforts around sort of social marketing and getting involved in sort of pushing particular products, but I think I'm talking about something a little bit more substantive in terms of engagement. On the critical pushing critical patients to the public sector, absolutely it's happening, because a private sector clinic doesn't want a mortality statistic on their book. It would really harm business. So they are pushing to the public sector, and the public sector is getting all those critical cases. cases, and they are dealing with them. I think one of the concerns, and one of the things that might be kind of a point of entry in terms is making sure there's good first aid care, so that that patient, when sent to the public sector hospital, is kept in a stable condition, so that they don't become a mortality statistic. And that's that is an area I think which we could think about strengthening emergency transport and first aid.
I'll just like to add to that. Yes, the public sector, somehow are bound to receive all those critical cases that were referred to. But from personal experience, as a doctor, as have served, for some time in a public sector, it's not without a grudge that we acknowledge that we are being, sent all the difficult cases and not maybe at the right time to actually save lives. Maybe at very critical condition when it's too late to do anything.
Just another thing is I think that the line is very blurry in Bangladesh between public and private because it's extremely complex, and the public sector doctors who are dealing with the critical cases are also the ones who are running the private clinics on the side. So it's really difficult to kind of relationship, and so investing in public sector provision in fact is subsidizing the private sector, but that's the way it is.
Okay, I think we should probably move on to the next presentation because we have two more presentations to